Good evening, everyone. Welcome to the first webinar in the Kidney Health series presented by Kidney Health Australia with WA Primary Health Alliance. For our first webinar today, we have the early detection and management of chronic kidney disease. Before we start, I'd like to acknowledge and pay respect to the Whadjuk Noongar people upon whose land we are meeting. I honour their elders past and present and recognise the continuing connection of Aboriginal peoples to their lands, water and culture. I also recognise the diversity and strength of Aboriginal peoples and the significant importance of self-determination and cultural knowledge in supporting the positive health and well-being of the whole community. Just some housekeeping. This session will be recorded and distributed to people who registered but could not attend. You've got the option to have your cameras on. I'd like you to keep your cameras on if you're comfortable. It would be nice to see your faces. If you have any questions during the talks, please pop them in the chat and we will answer them at the end. We also note that no AI tools can be brought into this meeting, please. This is our webinar disclaimer. And I'd like to introduce our two speakers for today. We have Professor Mark Thomas, who is a nephrologist at Royal Perth Hospital, and we have Sharon Cyril, who is a practice QI coach at WA Primary Health Alliance, so one of our own. And I will hand over to you now, Professor Thomas. Thank you very much.
Thank you very much, Michelle. Always a pleasure to meet people, either face-to-face or via the web. It's certainly a lot easier meeting via the web. So just a quick run through how to detect and diagnose and manage the early CKD, and just how much of it is around is pretty scary. And once again, we've got the wonderful Waggle territory where I'm talking to you from Royal Perth Hospital. I can even see a little glimpse of the Swan River from my very window. The peak, this is the Primary Care Educational Committee, has developed and reviewed this, and there's plenty of them putting some hard work. And luckily, we've got both written and web-based apps that can summarise all the information if you need to know a little more or you need to refer to it at any time. So they're all endorsed by Kidney Health Australia, means endorsed by me. Well done. So hopefully you'll have all the standard tools to pick up the kidney patients in your practice, and then which ones are at highest risk. Never forget to test their urine and then work out what you might do to slow down the progression. A lot of people get hung up on the C in chronic kidney disease and the fact that it's got to be there for at least 3 months. And when you want to say, is there something wrong with your kidneys? Well, our two easiest and simplest tools is your GFR bad enough to be below 60 for more than 3 months, and that's clinically significant? Or is there something else, even without a low GFR, that says there's something wrong with your kidneys? It might be something wrong with your ultrasound, say if you've got scars or blockages, or something in the urine, like a heavy proteinuria or hematuria, where you've excluded all the urological causes. So the number of patients who are actually kidney patients is pretty scary. 2.7 million, 1 in 7 have got either reduced GFR or albumin in the urine, and 3 in 4 have at least a risk factor, and it's twice as common as diabetes and can be pretty silent but pretty deadly. Unfortunately, less than 7% of people are aware they've got kidney disease, and the trouble is that it's very silent, unlike the polyuria polydipsia of diabetes, or the wheezing of asthma, or your aching of your arthritis. You'll have late referral as a common problem, and 17% of people only find out that they've got kidney problems in the last 3 months before they actually end up on dialysis. So it's very, very different now to when I was a trainee registrar back in Sydney in the early 80s, and I was taught confidently that if I had a diabetic with a creatinine of 150 and proteinuria, that the median time to dialysis was 18 months. And now if I see exactly that sort of patient, I'd say, phew, lucky you got here and found out about it. You'll probably never go into renal failure if we just do all the right things. And so this massive improvement in prognosis is, in my own clinical lifetime, it's just a phenomenal improvement. So here's a typical looking lady, 63, accountant, a bit of asthma, a bit of hypertension, and she pops in, just something else, my asthma, but she's carried issues with her weight, got a bit of an ache in her back, a little bit of blood pressure up and down, and a mum on my grandma's side who had a heart attack, but I suppose they had kidney problems, not sure what they were, a mother with diabetes, and a father with a bit of blood pressure. So very normal sort of person. She, unfortunately, is a smoker, and we're hoping that the new generational bans will make this a thing of history. And they say the definition of an alcoholic as someone who drinks more than their doctor. So she's not an alcoholic. So she's also knows about Ventolin, but that's all she takes. So do you think she needs a kidney check? Just running through this little list, she may not be diabetic, but she's got blood pressure and been a smoker and overweight. She hasn't had angina yet. She doesn't know of anybody who's definitely had kidney failure. Kidney problems doesn't. She hasn't had a wobble in her creatinine in the past. She's not First Nations, but she's now over the magic 60. So there's at least 4 out of several risk factors. And we'll see where that takes us. So, quick hit. Which of these tests should you do first up, just to screen for CKD in somebody with these issues? So the quick answers are GFR, BP, and ACR. So you don't have to do a first up ultrasound. As a nephrologist, I often do a protein creatinine ratio with my albumin creatinine ratio, but that's to pick up some subtle extra signs. And dipsticks can be positive in normal people and negative in diseased people, so it's not specific enough and reliable enough to sort out definitely abnormal from not abnormal. So quick hands up among the group if you can. Any idea how many of you know your own blood pressure? And we've got a couple of hands there. Oh, yes. So it's at least 60% of you. Well done. And how many of you know your own GFR? So one less hand in there. And how many know your own ACR? So congratulations to 2 of you. And it's amazing when I ask the questions among all GPs, it's not dissimilar. I've never been to a meeting where 100% of people know their blood pressure, and not usually more than 30% know their GFR and only about 10% know their ACR. The amazing thing is among WA kidney specialists, the numbers are exactly the same. There's a lot of my colleagues have no idea what their own blood pressure or GFR or ACR is. So let's see if that's a good rational way to approach things. So if you have got any of those risk factors and you want to look for CKD, then basically everybody coming through their GP should know their blood pressure. But if you've now come up with 1 or 2 or 3 of these positive on your screen, then when should you recheck? So If you've got a low GFR, that's the worrying one, because nobody wants to be on dialysis in a week or two. So repeat it fairly quickly, particularly, if it's completely new and it's down. And if somebody's ill and then gets well again and the GFR comes up, you don't relax. You just say, oh, your kidneys were tested and they wobbled. We'll have to look into this. ACR, less likely to be a major clinical problem unless it's very, very high in the nephrotic range. And blood pressures, once again, a clinical problem if it's symptomatic and up in the greater than 180s or 200s. So use your common sense as to how you do it. So once you've got someone with a risk factor, like a diabetic, or had a previous acute kidney injury, or with overweight or smoking or things, then even if you've done a test and they're okay, you've still got to keep on coming back and keep on coming back. And it's somewhere between every year to every 3 years if you've cleared it and been okay. So with risk factors, just because you clear once doesn't mean you're clear forever. And for First Nations patients, it's really ideal to go this kidney check every year. So every year, what's your blood pressure? Every year, a blood test, and always remember every year, a urine test. The urine test will often come up abnormal as one of the first signs. If you had to follow that through, once you've got your at-risk group, that the albuminuria, as you look for it, or the low GFR, as you look for it, and then follow it up. And these slides, I'm sorry if they're a bit repetitive, but it likes to repeat the fact. 3 simple tests, not sure, then follow your book. The reason that they keep on hammering on about these tests is that as your GFR goes down, you move into this red zone. And as your ACR goes up, you move into this red zone. And it doesn't take a very abnormal result before you jump a grade. So an ACR of 3 and you're into the yellow zone, and an ACR of over 30 and your red zone. And when you're talking about these red, it's a high risk of what? Of cardiovascular disease or dialysis, death or dialysis. And the percentage risks compared to what you would otherwise expect for your age are phenomenal in terms of how much it increases your risk. So dropping your GFR compared to a person of the same age, gender, and risk factors, if you've got a low GFR, you can have 5 times, like a 500% increase in your chance of cardiovascular death, and a 50 times risk of dialysing. And when you're talking about albuminuria, even if you've got a completely normal GFR, albuminuria of 50 or so takes you into the treble your risk of dying, and 50 times risk of dialysing. So very nasty outcomes that can follow on for very simple tests. For your GFR, that's been simplified compared to the old days where it was lumped into mild, moderate, or severe renal impairment. And one of the other useful factors is just appreciating it quantitatively, how much it goes down as you get older. And my quick rule of thumb is 140 minus your age. So if you're a healthy 20-year-old, you should have a GFR around about 120. If you're a healthy 50-year-old, you should have a GFR around about 90. And if you're a healthy 80-year-old, then you should have a GFR around about 60. So any GFR less than 60 means you're worse than an 80-year-old for your in terms of your GFR. So none of that is likely to cause you a single symptom. You really don't get symptoms from GFRs until they're under 15. And that's when you start, when the rubber hits the road and you're going to be deciding, do you want to dialyse, or could you have a transplant, or are you ready to make an advanced health directive and talk to the palliative care team? So there's lots of times when the GFR can cause alarm, but you shouldn't panic. So the GFRs, if your kidneys have suddenly stopped and somebody's tied off both your renal arteries or blocked both your kidneys with stones, and you're suddenly anuric, your creatinine doesn't go from 100 to 1,000 instantaneously. It goes up slowly day by day, about 100 a day. And even in an anuric state, when your GFR is actually zero, the lab doesn't know that. It just looks at tomorrow's creatinine of 200 and says your GFR is now 70, and looks at the next day's creatinine of 300 and says your GFR is now 30. And so the lab doesn't know that this is a dynamic situation with a changing creatinine. So don't use GFRs in acute renal failure. Talk about how rapidly the creatinine goes up and how much the urine output has dropped down. And you do need to be able to use both parameters to describe acute kidney injury, because a lot of our chronic kidney patients are prone to an acute on chronic insult. Once you're on dialysis, GFRs don't mean anything because the creatinine is not stable. It's all been taken out by the kidney, so it gives you by the dialyzer. And there are this other interesting group. We're now starting to see a lot of people who love going to the gym and having their creatine powders, their high protein powders. And the amount it jumps your serum creatinine afterwards can be virtually double your serum creatinine if you take it after the protein shake. So if you really want to get your true GFR, plenty of water, fasting, no exercise, no non-steroidal, and no protein shakes. When you have large people who are very muscular, that can generate a lot of creatinine. And so you see these bodybuilders who look like they've got kidney damage because their GFR is low, but it's not that they've got kidney damage, they've got muscle success. And for all these adjustments according to body size, then I always go to the National Kidney Foundation website and then type in my height, my weight, my age, gender, and the serum creatinine. And another incredibly useful new test that's available is cystatin C. And you can go to the same National Kidney Foundation website and type in your patient's cystatin C and take a huge amount of worry away from your patients by showing that, sure, your creatinine is high because of your muscles or your height, but your cystatin C is completely normal, and here is the numbers to show you that your GFR is in fact not a problem. ACRs more often abnormal than a decreased GFR. So if you're not testing urine, and that includes yourself, you're missing the early warning signs. And it's 62% of kidney patients haven't had their ACRs checked. So it's bad for patients and it's bad among doctors as well. The nice thing about an ACR, it becomes a very measurable marker of your improving health. And the three things which commonly push your albuminuria up are your blood pressure going up, your body weight going up, and your blood sugar going up. And as each one of these independently come down, you'll see your ACR come down. So it's something you can easily graph and show the patients how things are going. But the thing you always have to warn patients is that if you're in this overloaded, hypertensive, high sugar risk phase, that as you improve those parameters, it can actually drop your GFR a little bit. So that's worthwhile knowing, just to pre-warn your patients that as starting these renoprotective drugs or you're improving your health, expect your GFR to drop as we unmask how bad your kidneys were and how much you were overdriving them. I can go over that if you didn't quite catch it. So do an ACR, repeat it, and try and get it in a, if you want to get the lowest one, in first thing in the morning, but not after exercise. And protein creatinine ratios can be strongly positive where your ACR is negative in something like myeloma. And so albuminuria is a more sensitive test, but protein creatinine ratio is a more robust test. So endocrinologists tend to do albuminuria ACRs for the earliest pickup on a diabetic, whereas nephrologists tend to do protein creatinine ratios so we see the full extent of a severe nephrotic, for example. But grab a result whenever you can. There's plenty of things which can make it get worse, and that's not dissimilar to your blood sugar or your blood cholesterol. You can get your best blood pressure and blood sugar fasting and relaxed. You can get your stressed, high blood pressure, high sugar, and your ACR will go up and down in the same way too. So Audrey came back and, her creatinine's up, which means her GFR's down. ACR, which should be less than 3, is in the micro range, but not above 30. And her blood pressure is higher than you'd like, but this is in a clinic. So does that mean she's got CKD? Not quite sure how we do a web poll. I'm going to press on this red thing and see what happens. What it does, just take me to the next slide. So there is a maybe. So we don't know, it's not a definite yes, because we haven't hit 3 months yet. It's not a definite no, because there's obviously abnormalities. So if they persist, it'll be C for chronic. But it's certainly bad enough to make you want to check quickly. Blood pressures, everybody should be below 130, but one of the questions is how far below? And just as I said, the prognosis has so dramatically changed since I was a registrar. The blood pressure targets have dramatically changed. When I was starting, you were taught that the target blood pressure was 100 plus your age. So a 60-year-old should have a blood pressure of 160, an 80-year-old should have a blood pressure of 180. And the reason was our blood pressure pills were so bad that if you tried to bring it down to 130, you'd kill the person with the pill before they were killed by their high blood pressure. So it's wonderful now that our pills are safe enough to allow us to bring blood pressures down without causing terrible side effects. And the question is how far down? And what I like to do is, once I'm getting down into the normal range, under 130, is always use home blood pressure cuffs rather than look at what I'm treating in the clinic. And just treat the clinic as my stress test to see how much your body responds to the stress of coming to an appointment. And then keep on going, chipping away slowly until people say, okay, now I think I'm getting a bit dizzy. Because it's amazing how low healthy people's blood pressures are. So young women and children often have blood pressures of 90 systolic or less and run triathlons, feel well. And so if you're normally a 90, but now you've got a kidney disease that takes your blood pressure up to 130, then your blood pressure, your systolic, is 40 points higher than it would be normally. So please don't be coy about taking people's blood pressures down to the point of dizziness and then back. Just find each person's individual answer. So do it, but do it carefully, because as your blood pressure comes down, then your GFR may come down as well. And depending on what you treat it with, your potassium may go up. And with our starting line drugs, an ACE or an ARB, I always warn, watch out for a 10% chance of a cough with an ACE inhibitor, maybe a 1 in 1,000 chance of a swollen tongue. If you're in the fertile group as a woman, then you're allowed to continue it until you miss your first period. So it's not bad to be taking it at the time of conception. And for those people who have a cough, then you can swap to an ARB, or if you don't want to even have the whole cough conversation, you can start them on an ARB. When I'm trying to decide between the two, I say it's a trade-off of cough over cost over coffin, because in the large epidemiological studies, there is a marginal mortality benefit for being on an ACE inhibitor over an ARB. But there's no benefit at all if you stop your pill and don't persist. Once you've got kidney blood pressure, then it's never stop at 1. It's not even usually stop at 2. You'll often usually have to have 3 pills. And there's nice, good arguments, in fact, for initiating therapy with very low dose double pills, which often then counterbalance their side effects. So should we start her, or should we, sorry, I'll read this carefully. She should not be started on an ACE or an ARB because it's too early. True or false? Now, I'm not sure. Can you, hands up if you think it's true. Pop your answers in the chat, or even just nice quickly, so I can't see where the chat lines are coming up.
Someone has said B, false. Another one for false.
Right.
False. So 4 falses so far.
Terrific. Well done. Great to see people who be confidently right. So this is a false statement. The ACE and ARBs should be initiated early and can be initiated late, basically at any stage, as long as you watch for the drop in GFR and watch for the rise in potassium. And they are not just there to bring your blood pressure down, but for the same degree of blood pressure lowering, they will give an extra better preservation of kidney function and an extra better reduction in proteinuria. And you chip away and just try and bring the dose up to the maximum tolerated. It doesn't mean the maximum, it means the maximum tolerated. Watch for the cough, watch for the dizziness. So, as I said, GFR down, potassium up, but don't panic. If it's a little bit down, relax. And this says stop and then consider referral. Sometimes you'll find that just by taking it at night rather than day, having more fluid, that it's okay. But if you get a really big rise, then you may actually have unmasked something very important in that patient. And one of the important things you want to not miss would be renal artery stenosis. Or somebody with people. Right. Sorry, I can hear a voice coming through. But so if you do get a big jump in creatinine and a big drop in GFR, think about doing a renal Doppler, think about doing a cardiac echo, and look particularly for somebody with pulmonary hypertension. So high pulmonary pressures, low cardiac output, and renal artery stenosis, or someone who's chronically dry. They're the things which I would look for as the reason for why they had disproportionate drop. So she comes back a week later. GFR has not dropped any further. It's just stuck at that rate. urine ACR is actually a bit worse and the blood pressure is not improved. And even 3 months later, then things are only a little better. So that to me is all a little bit surprising, because if I could see that things were like that, hopefully she was, there it says, started on an ACE at the second visit, in which case that drop in blood pressure is a little less than you'd like. You really like it to come down a bit further. And that drop of ACR is a little less than you'd like it. You know, with a decent dose of an ACE inhibitor, you could get that 30 down to a 15 or less. So that would suggest that, yes, you're being on the very gentle side to bring her down. Now, you can see that she was carrying a bit of weight, and there was no mention in this case history of all the reasons why she might have got to that state. So as we go through this, I'll try and take you from the very simplistic, here is the kidney treatment, here is a kidney pill, and you've done your job, to some bit more treat her as an individual and work out why she's got this problem. Here we now know she's got chronic kidney disease and she's in the micro group and the GFR down. As a 50-year-old lady, she should have had a GFR of 90, but it's now down, sitting around the 50 mark. So this is kidneys that are older than an 80-year-old's. And that is colour-coded plans going from yellow to orange to red is a very simplistic strategy that the Kidney Health Australia has put together. And most of it just changes two different things. One is that how often you're seeing them and how many tests you do. And as you move into this orange zone, then you start to think about the effects on your bones and your hemoglobin. And you're doing iron studies because keeping your ferritin at the top of the normal range is first step in management for CKD anemia. So you don't just avoid iron deficiency or accept low normals, you know, you're using your intravenous treatment to try and keep it high. Calciums and phosphates are a very two-edged sword. If their calcium is too low, it really stimulates your parathyroid glands, and that will accelerate hardening of the arteries and weakening of the bones. But if you overtreat with calcium, then you can end up with too high a calcium combined with a high phosphate, and you then start calcifying your arteries just as badly as if you let the parathyroid do it for you. So the whole trick is getting an optimum diet and optimum pills and optimum PTH. And I treat this as renal whack-a-mole, where for everything I try, I'll usually make two things better, but one thing worse, and just trying to find the best trade-off. So we're now trying to think of all these different areas, because there's a lot of different diseases which your kidneys can be knocked off in as part of the collateral damage. But once your kidneys are knocked off, then you get this flowering of red flags in the pathology and in the prognosis and in the collateral damage, which are going to then make them, you know, polypharmacy patients and shortened lifespan if you don't really act well and act hard. So the Kidney Health for Life program, this is a new program which embeds that holistic approach that I absolutely love. I couldn't believe how, as I flicked through the different tabs on each of the health for patients, diet for patients, mental health for patients, it was just music to my ears. So Maria, who put this together over the last decade and has now just released it online, needs to be made a saint. Here are some general things you can say about eat healthy, and this is the wonderful simplicity about modern health, is that this is good for your brain, for your heart, for your joints, and for your kidneys. There used to be a recommended of how many drinks you should drink a day, and we realised, in fact, that whole campaign was sponsored by Coca-Cola Amatil to make them sell more Mount Franklin water. And once people looked at the science and then realised they'd been taken for a bit of a ride. It's nice to basically avoid thirst, but if you want to make your urine pale and plentiful, that's a good way of reducing your chance of kidney stones and urinary tract infections. The big killer is soft drinks, and even the sugar-free, artificially sweetened ones will put on your body mass index. Anybody who hasn't read or say hasn't watched the Super Size Me movie, really get it out and just remind yourself just how dangerous junk food and soft drinks are. Salt is in so many foods and in so many drinks. I don't know if you looked on the side of a can of V or a can of Monster or Red Bull, but they've got, as well as a lot of caffeine and as well as a lot of sugar, they've also got a lot of salt. So trying to provide tasty food without us salting it is a little bit of a trick. So here's a Thomasism. I say, I'm going to go through, help you look after yourself, spelt with an extra F: sleep, exercise, love, food and fluid. And for each one of these, there's a right amount for you, there's a good quality for you, and there's a right cost for you. And if you approach these things as a friendly, fun thing, then I can really recommend the 4-word sentence, what makes you smile, and getting that person on side and then finding out what they like doing so that you can talk about the exercises on the foods that they like, not that you just have to say work for you. Eat like a hippie, not like a truckie quickly embodies everything about the Mediterranean diet, and people who are truckies need to be validated that they have to eat quick and cheap and filling. But it is renal and cardiac and metabolic pathway short to a sad end when you look at just how many calories and how much cholesterol goes up with a big pile, with a double cheeseburger, a pile of chips, tomato sauce, a can of Coke, iced coffee chill, and a couple of monsters on the way. So not salting is, use things like pepper, garlic, lemon, and ginger. And heart salt is actually very nice. You can get this from various supermarkets. And instead of sodium chloride, it's potassium chloride. So you've always got to check the electrolytes first. But it's a really salty flavour. I really can't bear it because it's so salty. And, for the person who's trying to work out medically why you do it, you just say, well, potassium is the anti-sodium. The more potassium you put into your body, the more sodium you push out. So think of each of these things. And if your patients aren't smiling, well, they may have a sleep-love imbalance. And if they're not in that normal range, either they're too skinny or too overweight, then they may have a exercise, food and fluid imbalance, which may be then driven by a sleep, love and balance that you want to just let them tell you what their challenge is. And when people, and a lot of my patients are, 120, 150 kilos, if they can walk into a clinic, then the physical lower body strength that it takes to lift your body without walking aids when you're sort of 60 kilos overweight, these people have got Olympic type quads and glutes. So I'm giving somebody a bit of credit for what they do on a daily basis. When I try and look at somebody's body weight, and it's a really critical thing when you're on dialysis, fluid shifts, if you misinterpret that gain as gain in body fat, and then you try and squeeze it out of the machine, you can kill somebody with severe hypotension. So very important to be precise. And I stopped talking BMI because I've never found a doctor yet who can tell me roughly how much one BMI unit weighs. But the answer is about 3 kilos with a range of 2 to 4, 2 for short people and 4 for, but it takes so much explanation and maths and all the rest. Far simpler just to say, what's your height in centimeters, knock off the 100, that's roughly your BMI 25 weight, which might be where you want to get back to, but build your muscle, keep your bone, keep your fluid right, and let people tell you what they want to do. Finding a good exercise for people is also very individualized, and some people are very fit, but they're not stable, or they're very strong, but they're not flexible. And so for the people who can still walk, the 7-minute fitness program, or getting down like a bird and up like a rocket, half squats, 10 before you eat a meal so you burn it, and 10 after you eat a meal so you burn it, is a way of getting people who don't usually move to enjoy it. For people who are stuck in bed, then getting them to kick in bed and cycle in bed and box in bed. I call that my bed Olympics. And for the people who are stuck behind an Uber steering wheel or behind a receptionist desk, then the wave of steel from your calves all the way up your body to your neck, and then slowly melting back down. Just repeat that over and over every sort of minute or so, and you can have somebody who's doing isometrics, which keep them fitter. And for bad backs, planking Pilates and Panadol, but even just simple posture. So I call these my 4Ps for fixing backs. And you've got to make sure you've got a good motivation that's appropriate for that person. For my 8-year-old, so you want to get stronger and fitter so you live longer, so you don't fall. And your 50-year-olds, so you live longer. And your 20-year-olds, so you look hot. So that hopefully they think it's fun and I think it's fun, and then we can talk about how to keep it fun. So it's amazing how many calories are in one standard drink. Anyone want to make a wild guess in the chat? If you had the amount of calories in 1 teaspoon of sugar, then how many teaspoons of sugar are there in one standard drink? So anyway, the answer is 5. Well done, Rachel Stephen. You get the brownie prize. So it's very easy in a big glass of Chardonnay to get 2 standard drinks in one glass. And if you have 2 Chardonnays, you're actually talking about sort of 4 or 5 standard drinks. 1 bottle, 7 standard drinks, same as 35 teaspoons of sugar in terms of the calories going in, which is why you get a wine gut or a beer gut, quite apart from the stuff around your liver. And we're now seeing how much obesity actually impacts all your organs. Right. So should we use an Australian risk calculator? I think yes, you can put a little yellow hand on your hand up. And the surprising thing here, so if all of you think you'd like to calculate that because she's at risk, then you're absolutely right. But in fact, the answer is already she's at big risk, because just the presence of albuminuria automatically jumps her right up. And if she was not only with albuminuria, but First Nations, that would double her up into the highest risk. So high risk, greater than 10% chance in 5 years of dying, and GFR less than 45 or ACR over 30, bang, you're in there. And in the slot, almost there, GFR less than 60, and micro rather than macro, and you've already jumped up a category. And if you're already in the intermediate because of your hypertension or your weight, then you lose it. So virtually all of my patients, very high vascular risk. You don't want to be my patient. Lipids is good for protecting your heart, but doesn't actually protect your kidney. And the cardiac protective benefit is attenuated as your GFR goes down and down. The lipids become less and less good at protecting your heart. And it's not that they don't work, it's just that there's a whole lot of all this calcification and hypertension that's damaging your heart, apart from the plaques, which the lipid pathway. For your blood sugar control, the trick is as your kidneys get worse, your diabetes often gets better. And the people who are really approaching dialysis, they may be stopping pills to the point they're off insulin and off everything and constantly at risk of hypos. So all these things, you've got the risk if you don't do enough and the risk if you do too much. The plans that would be good on well days, they have to be suddenly flipped on sick days. So yes, it's nice to get a fasting lipid profile. And if you do happen to be comorbid, you've got kidney disease and ischemic heart disease, and then hit hard. And we're very lucky that not only have we got good lifestyle advice and simple pills, but we've actually now got the new injections, which are PBS funded if you meet the right criteria, so you can really achieve wonderful statins, wonderful intense control. So she's not diabetic. Should she be on an SGLT2? And you can either put something in the chat or you can put a hand up if you say yes. So all the trues and the hands up. I'd love to see that, because like the ACE inhibitor, there's no too early and there's no too late, and it's a benefit that is not just for your kidneys but also for your hearts. And unlike a statin, where the benefit wears off as GFR goes worse, in the SGLT2s, the heart benefit, the kidney benefit stays there no matter what GFR. And unlike an ACE inhibitor or ARB, whereas you protecting the kidney for long-term chronic renal failure, but you increase the risk of acute kidney injury, SGLT2s protect you against long-term kidney failure, but decrease the risk of future kidney injury. So they are both groups of drugs, the ACEs and the SGLT2s, are temporarily withheld if you have acute kidney injury. But those patients who are on them are less likely to have those acute events. So a double protecting agent. And very underutilized. Half of eligible people were not treated with an ACE and with an SGLT2. And in fact, I've seen much worse statistics. I've seen like 90% of eligible people not treated with an SGLT2. It depends which survey you're doing. So the prediction is that there'll be thousands of people with a cardiorenal or a renal failure benefit, knotting it up on dialysis. And does anybody in chat want to have a wild guess what 1 year of in-centre dialysis costs the Australian taxpayer? The answer is $180,000. And we actually get to about $10 billion a year just for the dialysis population in Australia. So a sizable slice of your health dollar with a very preventable strategy if you pick them up early and treat them early. So you've got streamlined criterias, and you don't need albuminuria if your GFR's in this 20 to 45 range, and you don't need much albuminuria, just in the high micro group if you're anything right out to 90. And they would like you on an ACE first and then an SGLT2. And the interesting thing is, although it says that we're not going to pay for it if the GFR is less than 20, it's not because it's unsafe. It's just currently yet unproven. But we're right in the middle of a worldwide trial of SGLT2s in advanced stage 5 CKD, in dialysis, and in kidney transplants. And they certainly do no harm on dialysis, and we're hoping that it actually will, even though your kidneys are gone, it'll be extra benefit for your heart, will keep more people well and off dialysis. I mean, out of hospital. So yes, your GFR can drop, but it's a bit slower than the ACE inhibitor drop, and it's because it's gentler, if you like, a so-called smart diuretic, then you don't usually need another diuretic, but it does it more by reducing all the fluid, not just intravascular, but also interstitial. Whereas things like loop diuretics very much drop your intravascular volume and much more likely to cause you to get acute on chronic renal failure. So if you are on a diuretic and your blood pressure is quite tightly controlled, but you want to start an SGLT2, why not swap the diuretic to the SGLT2 and see how you go. So if your kidneys are down to the sort of 30%, 60% range, and you're about to use a renally excreted drug like metformin, then treat your GFR as your dose percentage. So if you've got someone with a GFR of 20 and your normal dose of metformin is 2 grams, then what's 20% of 2 grams? And then just give them the nearest effective pill. If you're big and tall and strong, you can use the pill higher. If you're short and scrawny or amputated, use the pill lower. And with renal patients, really tell them about the side effects. So, I'm going to start you on metformin, but if it's too strong for your kidneys, then you might get nausea, or you might get diarrhea. And if that happens, then stop it for a while and then restart half the dose. So that narrow therapeutic index is very important, and making sure your patients are educated and know what they're watching out for, and then let them come back and tell you what's the right dose for them. The long list here is things that you've got to be careful of, but there's actually 3 separate questions you need to ask yourself if you're prescribing for a renal patient. One of which is, is this pill renally excreted, in which case dose adjust to your GFR. And the second, does it worsen kidney impairment? And you may have something that's not renally excreted, like an angiotensin receptor blocker, but can drop your GFR. And the third thing is, does it worsen something that a kidney patient already has? Does it put a high blood pressure higher, like prednisone or nasal decongestants or non-steroidals? Does it make an oozy patient oozier, like your dual antiplatelet therapy post-stroke? So I always ask those 3 questions: renally excreted, nephrotoxic, or worsen something that's already bad. So who needs to come through to the teaching hospitals? Well, there's a long, very small print little algorithm, but I've got a simple 30-30 rule, which is, let me just see if it may not have the little X on the, there we are. If everything's stable and your GFR is over 30 and your urine ACR is under 30 and they're well, they're great GP patients. So no need to worry about it. But if you look at this stage by stage, The opening one is what you already know. What's CKD? GFR, ACR, and is it chronic? Don't forget the investigation to work out what sort of CKD. So get an ultrasound, get an MSU, and use your brain. And having decided what stage you are, work out, is this a super serious one? The ones that better go and see somebody and, or, really work hard together. So rapidly progressive, or blocked kidneys, or out of control blood pressures, something with, so have a look at the fine print on this one, because they're the ones that are all the little list of red flags there. But none of those apply. Everything's stable. Relax. So for those who do come through, these are the things I love to see. So don't forget the MSU and the ultrasound. And it's not just what's happening in your kidney, but remember what's happening in your bladder and your prostate can be very important. And people with concurrent liver disease become a very tricky balance. So MSU and ultrasound, two wonderful extra things. Interpreting your height and weight allows, and then knowing how much of that is muscle, fat, fluid, or bone gives a much more intelligent way of looking at your creatinine GFR, that you're likely to be better than average, you're likely to be worse. If you think that this is all an acute situation, then knowing how wet or how dry somebody is crucial. So you can do this as 5 measurable things: their weight, their edema, their blood pressure, sitting and standing, capillary refill, and if you're good, a JVP. With a chronic kidney patient, then I love a 5-point weight history. So people whose birth weight was less than 2.5 kilos, whose teen weight when they stopped growing upwards is very different from either their heaviest adult weight or the minimum adult weight to their current. And for these extremes of the range, when do they occur and why? And those simple 5 points and 2 extra questions, the things that come out of people's mouths is inspiring and chilling. And often in 15 minutes, I'll have someone who bounces in with a bright smile and then walks out sobbing and saying, "Thank you. I've never told my husband that, but blah, blah, blah." And you suddenly realize why somebody smokes like a chimney and drinks like a fish, just to sort of stop themselves shaking. So very important 5-point weight history there. Seeing how things have changed in your observations and electrolytes, and looking at the pills that have stopped. So things that might have been beneficial have been withdrawn. So hopefully you know the sad man's list. And remember, PPIs are quite a common nephrotoxin, but a very tricky one because it's a slow motion one that does nothing in the urine. And so it's like this gradual hardening or leathering of your kidneys. And so every time I've got the option to get somebody from a high dose PPI onto a as required with a high dose H2 blocker, I always think that's a good move. A pregnancy is a fantastic stress test for your kidneys. So if you came through your pregnancy with no diabetes, no blood pressure, no problems, then you've got a much better prognosis lifetime. And what else might be in the family is very useful. So for our First Nations, they're much higher risk. The renal failure progresses much faster. And a lot of this is just this sort of every step along the renal risk factors. Aborigines just get the short straw every way. Just racially, there's fewer nephrons per kidney, with larger glomeruli per kidney. And then the smoking rates, if that's in your mum when you're born, and if then you're born small and then get pushed into the child feeding program, which then only allows you access to Coke and white bread and chips, then it's like a renal failure factory. So when I first arrived in WA, I was told, don't ignore proteinuria in Aboriginals, it's racial. I said, really? Okay, are you sure? Gee, what happens if I start an ACE inhibitor? Oh, it gets better. What happens if you lose weight? Oh, it gets better. And what happens if it's just I found it was much more neglect than a real difference. So there's plenty of things you can look through, just see how many of your patients do have an ACR check. Really try and let them tell you what works and what doesn't work. Use your practice nurses to and code them, and think about your recalls lists and make sure you get properly reimbursed for everything. I love this new initiative, the Kidney Health for Life, available both online and as an app. And there's the links, the flyers, so highly recommended. So here's a little chance for a Q&A, but we're going to hear something important from Sharon.
Okay, good evening, everybody. Yes, after all that wonderful clinical content, I'm just going to run you through a very quick and easy way that you can identify your patient cohort with CKD in your practice using the Primary Sense Chronic Kidney Disease report. For those of you that aren't familiar with Primary Sense, it's a data extraction tool owned by the primary health networks. Specifically designed for Australian general practice. It is provided at no cost to eligible general practices with compatible software. It extracts de-identified data from the clinic and then applies some evidence-based algorithms to then provide real-time medication safety alerts and care prompts at the point of care in the practice. And we can also run reports for the purposes of quality improvement and also population health. So what it looks like in practice is that each user has a little desktop app on their desktop, and you simply just click on the reports tile, and then the reports list will appear, and you double click on the report of interest. So in this case, we're looking at the chronic kidney disease report. Now, that report will take a little bit to run, so I'm going to show you one that I have prepared earlier. Just bear with me while I share my screen. Okay, hopefully you can see that okay. So what we've got here is our report in which Primary Sense has essentially done all the hard work for you. It's analysed and collated all your practice data to identify your patients that may be already have chronic kidney disease or be at risk of chronic kidney disease. So you will notice this is a demo report. So the lists that I'll show you are probably quite short for the purposes of being a demo, but in practice, the list of patients you get in when you run this report might be quite long. But the actual reports themselves are the same as what you will find in practice. So I would always encourage you, when you look at these reports, to just expand these blue boxes, because it does give you a breakdown of the criteria that has been applied to these reports. And essentially, these reports all are along the guidelines in the Kidney Health Australia Kidney Health Australia Primary Care Handbook. So they are expandable boxes I would encourage you to have a look at to understand what's happening here. And we have 4 tables which also have expandable boxes. Our first table we're looking at here is our patients at risk. And you will note here, if I scroll across, that we've got the 3 parameters for your annual kidney health check. In practice, you'll probably have a much longer list than this, and you'll probably get quite a few with blanks across here, so that you would potentially want to focus on recalling those patients. If I scroll down, you will see we also have a table for patients with a yellow clinical action plan, which has different data points applied to it, a bit more in detail, and then same for the orange and then the red, and each one has their own explanatory box as well. So the way you would use this report, or the ways that you can use this report, Each of these headings have sorting arrows, so you can sort by whichever factor you might be interested in. For example, you could want to focus on the highest BMI in the cohort to target them for a recall. You can also use the export to Excel function here, which essentially you hit that button and you get a spreadsheet of exactly that table that we're looking at. And then you can use the filters on your Excel to drill down even further. Obviously, you can select your various data points that you want to look at there. I will just mention the ACG complexity score, if you're not aware of what that is. So this is the Johns Hopkins algorithm that is applied to practice data. ACG stands for Adjusted Clinical Grouping. So it's a highly respected algorithm that gets applied to patient data to allocate them a complexity score which indicates their care needs. So that ranges from a 0 to a 5. So a 5 would be your patients that have the most complex conditions, the most medications, for example, elderly, or they could even need end-of-life care. So that is one way you can also target a cohort of patients is by looking at that ACG score. Okay, so go back to the presentation. I will just let you know that we have a team of quality improvement coaches around the state, and we are more than happy to come to your practices to help you run these reports. Even though it is very simple to do, we can help you run these reports and interrogate the data as you see fit. But I'm going to hand back to our host, Michelle, now.
Thank you, Professor Mark, and thank you, Sharon. For the contact details for the QI coaches, please see that on the screen. I can also pop them in an email that I will send post-webinar to everyone. Now we will take questions, and one question has already been asked in the chat. I think this is to you, Professor Mark. I am aware we are a bit over time, but I think since we've, everyone has stayed, it would be nice to do some questions. Do you consider EGFR all the time that utilizes standard body size, or do you consider IBW/actual body weight in patients with low BMI?
Yeah, the actual body weight. Always try and make your data relevant to that patient. And for people who are very wasted or got anorexia, you can have quite serious kidney disease and completely hidden and camouflaged by the low muscle mass, which gives you a low creatinine. And one of the most tragic cases I saw was a 25-year-old girl who'd vomited from the age of 13. She had the osteoporosis of a woman of 70, and anything that went into her mouth would be chucked up, and she was on dialysis within a year, and she's still on the dialysis now at the age of 55. But the day I met her, I said, I promise you I'll never let you have a kidney transplant, because every pill would vomit up, and all of our kidney transplant patients would get much worse bones. And within 5 years or so, many falls she had. It was terrible fractures. So we've talked a lot about being overweight, but the dangers of underweight are terrible.
Thank you. Does anyone have any other questions? You can either unmute yourself and ask them, or pop them in the chat.
Or send me an email. I'm here. I've been at Royal Perth since 1988. It's probably keep on going for a few more years yet.
Wow. Another question, are protein supplements dangerous to the kidneys longer term?
Protein supplements, well, it depends if your kidneys are completely healthy kidneys, and you can probably push to the max and then no problems. But if you've got, I certainly see bodybuilder kidney and people who, push it and then they get a little bit of proteinuria and then keep on pushing and they get more proteinuria. And it's not just the protein supplement, but often the bench pressing, which goes as all part of this more extreme body building. Do you know how high your blood pressure goes during a maximum bench press? Goes between 350 and 400 millimeters of mercury. So I was a bit of a crazy 15-year-old gym going as to do part of my rowing training. I actually had left ventricular hypertrophy at the age of 16, a bed that used to shake when my heart beat, which is now all shrunk back. But, you know, interesting to see. And those people who then put steroids on top of their bench pressing and their protein shakes, they can easily knock off their liver and their testicles at the same time. So be careful. Eat like a hippie, not like a truckie. Remember, think Bruce Lee, not Schwarzenegger.
Any other questions for Professor Mark or Sharon? Anka said thanks for the session tonight.
Well, ANCA is a very famous renal abbreviation because it's the, as you, I'm sure you know, you're very rapidly progressive.
In the interest of time, I think we will wrap it up now. The next kidney health webinar will be speaking to managing chronic kidney disease alongside other chronic conditions. That webinar, I'll send you the date as soon as we finalise it. Thank you so much to Professor Mark and to Sharon for presenting tonight. Your expertise is greatly valued. And to everyone else for taking the time to come to this session tonight and for engaging, asking questions and engaging with the quizzes as well. I hope you all have a very good night. I will send out the link to this recording and any post-event paperwork Kidney Health Australia will send out also. So thank you so much, everyone. Have a great night.
Okay.
I will end the event. Thank you.
See you all. Bye.